So I think people will continue to join, but we have a lot to cover, so perhaps we can get started. So Daniela, if you can move to the next slide, please. So hello, everyone, and welcome to our patient engagement open forum session focusing on prioritizing women, including mothers, in health research and development, which has been organized as part of Safe Motherhood Week. I am Helena Harnick, and I am with you here today on behalf of the Motherhood Collective Impact Program and Safe Motherhood Week. And we are excited to have you all here. And there was a message before, but please feel free to say hello in the chat and let us know where you are calling from. So a few housekeeping points on the next slide. So we're here, we wanted to have an interactive kind of format. So we're in a kind of regular Zoom meeting. If we could please ask you to keep yourself on mute so as not to disturb the panel when the panelists are speaking. But rest assured, you will have your chance to ask questions and interact with the panelists. We would like to suggest that you use the chat box for sharing questions during the panel, and you can also indicate by raising your hand if you wish to speak during the Q&A session, which we will set aside a few minutes at the very end. For your information, the session is recorded, and we will upload the recording to the Patient Engagement Synapse platform and Maternal Health Synapse platform for your reference afterwards. So I hope you're ready for a fantastic discussion today. Just before I kick things off, I wanted to say a few words about the Patient Engagement Open Forum if you are new to this series. So this is a series of virtual and in-person events where we work together in a multi-stakeholder context towards stronger patient engagement and shaping the future of patient engagement. And we are really looking forward to leveraging the collective intelligence of the Patient Engagement Open Forum community to tackle this very important topic of women-centered R&D. And if you could move to the next slide, please. As I mentioned at the very beginning, this special Patient Engagement Open Forum session has been organized as part of Safe Motherhood Week, which is an annual awareness week that was established in 2015 to respond to the risk of maternal health being completely abandoned as a priority topic. It's a focus for public engagement and action, and aims to give a voice to real women and to raise awareness of the persistent gaps and the need to collaborate to address these gaps. This year, our aim is to shine a light on the importance of prioritizing women, including mothers, in R&D as a priority topic, and to build a momentum for collaborative partnership to address these issues. Your input from this session will help to identify collective actions that can be taken in the next 6 to 12 months to address these issues and enable a positive experience for women, mothers, and their children everywhere. We especially hope to hear from the patients and the patient representatives in this session. If you could move to the next slide, please, Daniela. We are honored to present a panel of distinguished experts, each bringing a wealth of knowledge and experience to the forefront of our discussion. And it is my great pleasure to hand over to our esteemed moderator, Dr. Eleanor Nwadinobi, who is the international president of the Medical Women's International Association, who will open the discussion and guide us through this enlightening session. Eleanor, over to you. Eleanor, I believe you're still on mute because we're not able to hear you quite yet.
There I was. I started talking and I was still on mute. Can you hear me now?
I can hear you, Eleanor, but the connection seems to have somehow been interrupted since a few minutes ago. So I'm wondering if perhaps it's better now, or perhaps we can try without the video. It seems to be better now, though.
All right. How about now?
It's much better now.
Great, great. Warm greetings from Abuja, Nigeria. I'm glad you can hear me loud and clear now. Yes, today we are looking at patient engagement and prioritizing women, including mothers, in health research and development. Despite the fact that women constitute about 50% of the global population, women's health remains an underserved area, frequently lacking attention across various institutions, be they political, scientific, economic, etc. we have a newly published report, the Women's Health R&D Opportunity Map, thanks to a wonderful collaboration between the Bill and Melinda Gates Foundation and the National Institute of Health that had broad consultation. And it states very clearly how women's health is a neglected area of research and investment. But guess what? I'm not one of your erudite panelists for today. I will leave it to them to tell you more. And who are these erudite panel speakers? We have with us today Dr. Ru Fong Cheng, who is the Gender Equality Division Director with the Bill and Melinda Gates Foundation under Women's Health Innovations. We also have with us today Dr. Rishma Dillon Pai. She is an honorary consultant gynecologist in India and has served as president of all three leading gynecological infertility and endoscopy organizations. We have with us today Dr. Metin Gulmezulu, Executive Director of Concept Foundation, himself an obstetrician gynecologist by training, formerly with the Department of Reproductive Health and Research at the World Health Organization. We also have with us Marilyn Wilman, who is with the medical safety lead with Novartis. But before moving on with the panel, I'm going to turn over to Helena because we will be launching an interactive question via Slido to the audience. Over to you,
Eleanor.
Helena.
Thank you. So we are going to keep you awake, and there will be some moments when we'll be inviting you to participate. So Daniela, if you can move to the next slide, please. Hopefully the Slido should launch automatically. So we will be asking you this one question to say in one word, what are the most important opportunities today regarding So I hope you're able to catch that. So if you could just go to the Slido link and then you can respond to this quick question we have. If you could just share in one word, what are the most important opportunities today regarding women-centered research and development? And we'll just give you a moment to get there because we know that it's not always easy. Great, we see you're joining. So some ideas there, representation, clinical trials, multidisciplinary. It's tricky to keep it in one word, isn't it? But we appreciate that you're trying. Okay, we'll give everyone another minute or so. A lot of data, this is very interesting. Gender appropriate. Shared decision making. Fantastic. And also pregnant and lactating people. That's an interesting one as well. Okay, fantastic. Thank you everyone for sharing that, and keep that in your head because we will come back to that in the panel and in the Q&A a little bit later. And we will keep that open, I think, so you can still continue to, thank you for sharing. You can continue to add to that. Back over to you, Eleanor.
Thank you so very much. Isn't it amazing that we could actually also see some creative thinking around what constitutes one word. Thank you for that very interactive session that we kicked off with. Loved it very much. Okay, so now the time has come for us to hear from our panelists. I'm going to start with you, Rue. Tell me, Rue, what does women-centered care and R&D look like to you? And as you answer that question, there's a follow-up one. Where are we today?
Well, Eleanor, thank you so much for that question. Let me just start by saying thank you to Helena and the Synergist for inviting me to be a part of this panel. And it's so great to see Eleanor, Dr. Pai, Dr. Mateen, and Mariolyn. I don't think we had a chance to meet before, but so wonderful to share this virtual platform with you all. Eleanor, to get back to your question, I'd like to focus on the R&D side and then talk about the care side, because it's really a continuum, right? The R&D informs the care. And then before I get into the content of my answer, I just want to start with a couple of background terms, if you will. So you started off by talking about sex and gender. We know sex is different than gender. Sex is biologically driven. It's a biological variable, and that can inform and influence health outcomes. Gender is a social construct, which is how someone sees themselves, but also how the care system interacts with the person. And so it's different than sex, but it also can have an influence on healthcare outcomes. And so when I talk about women's health, I just want to be clear that I'm speaking inclusively of those who define or see themselves as women, recognizing that not everyone who identifies as a woman is biologically has a female sex. I'd also like to say that when I'm referring to women's health, it's broader than just what has traditionally been bucketed as women's health, what people have called bikini medicine, which is the parts of the body that are covered by a bikini bathing suit, meaning just breast and pelvis. And I think that has been the definition for so many years and for such a long time. And we are trying to move beyond that, because we recognize that every condition or disease that affects women affects women differently, or affects women disproportionately, should be called women's health, or actually even health of women. So, okay, now turning to the R&D side, I wanted to share some numbers with the audience to kind of help frame the issue. If we start in the care side, women make 80% of healthcare decisions for their families. Women are frequently referred to as the chief medical officer of their family. Women make up 51% of the population, so just slightly over half. But when it comes to human clinical trials, men actually make up 67% of trial participants. You can see that there's some things are starting to fall off here. And then when you move further up the R&D into earlier development, in animal-based research, male models are used 80% of the time. And then in cell-based research, sex is unspecified 76% of the time. So you can kind of see here that it's baked into the R&D process that representation of women or females is not proportionate to what we see in the population. Turning to the care side, I will just say I'm a physician myself. I'm an OB/GYN. I think I'm in a community of OB/GYNs on this call. And part of the reason I went into clinical practice was because I wanted to take care of patients, and it was something that was important to me. But physicians are trained in medical school, and with data that's actually generated from studies conducted many decades ago, which were and still are skewed towards male participants, right? And then when you look at what medical students are trained on, journal editors who make decisions about what research is published are actually 1 out of 5 are female, meaning 4 out of 5 are male. When you look at practice guidelines, they're based on data from studies that are male biased. And then when you look at academic medical education faculty, you'll see that 41% of all specific gender identified full-time faculty at academic medical centers are female, so less than half, while only 25% of full professors, so as you move up in the academic ranks, and 18% of department chairs are and deans are female. So really, you know, to answer your question, what does women-centered care and R&D look like? It's really about equitable and inclusive care. It's about framing the care journey from the perspective of the woman and putting the woman at the center of the care. Because our healthcare system is so complex, and it's not about the patient at all. It's really about the system. It's not designed to facilitate and make it easy for patients to move through the system. And women have unique needs and considerations as they move through that care continuum. And on the R&D side, it would be ideal to see representation of women at every step along the medical research and care continuum, including all of those aspects that I just mentioned. It's because of research on sex differences that we're just becoming more aware that sex and gender play an important role in health outcomes, including how diseases are prevented, diagnosed, and treated in women. And there's many examples. I'll just give you one small example from my previous role in the pharma industry. And it was an example involving psoriasis, which is a skin condition, right? That roughly is estimated to affect males and females in the same proportion. But when we looked at data around the mental health and emotional impact of psoriasis, we found that for females who had the same amount of skin involvement with psoriasis as males, they had a greater impact in terms of mental health and around social impact. So it was really interesting to see. And it's the kind of thing that if you don't look for it, you won't see it. So I have to really commend the NIH here, the National Institutes of Health in the US, for requiring reporting of results in a sex disaggregated way for studies that they've funded since 2016. And this reflects a little bit back to your question originally, Eleanor, about where are we today? So we're moving in the right direction, but I wouldn't say we're quite there yet. In terms of R&D funding, women's health R&D is actually severely underfunded in comparison to the burden of conditions. If you look at cancer funding, for example, if you look at data from the US National Cancer Institute over 11 years from 2007 to 2017, it actually shows that GYN cancers receive much less support than other cancers when accounting for the lethality, meaning the number of years lost for each new diagnosis. And in a selection of 19 cancers, ovarian cancer ranks number 5 for lethality, meaning it's the 5th most deadly, but it's actually ranked 12th in terms of funding. Cervical cancer follows a similar pattern. And so you'll see this for many of these GYN cancers. I know we have a European-based audience here. So if you look at the UK Medical Research Council, they provide figures on their funding for women's health, which includes research on preterm birth and perinatal health, and long-term studies such as the Million Women Study, which looks at the effects of diet, smoking, and other factors on disorders including cancer and heart disease. And what they reported is they spent 96 million pounds, which is 119 million US dollars, in the 5 years from 2014, which is roughly equivalent to how much they spent on cardiovascular disease in the same time period. And they spend 325 million pounds a year on health research overall. So when you look at funding, like I said, women's health is grossly underfunded. And it turns out that the Bill and Melinda Gates Foundation is the second largest funder of women's health R&D, second only to the NIH. And so we decided to do something about it. And in this year-long process, we created the Innovation Equity Forum, which Dr. Eleanor mentioned briefly at the beginning. We at the foundation believe that women's health is at the core of women's power and their ability to live happy, prosperous lives. And we also know that when you elevate a woman through her health, you elevate her child, her family, her partner, her parents, her entire community. And so it's really a high return investment to make. And we're also framing it as a gender equality issue. We know that until women can achieve equality in terms of health, gender equality will not be reached. And we know that's a UN Sustainable Development Goal. So our team, in conjunction with the NIH wanted to bring together a group of people, experts. So we brought together 250 diverse experts across sectors, across geographies. There's representation from over 50 countries. There's people from large organizations, small organizations, public, private, patient groups, industry, nonprofits, et cetera. And we tasked the group with developing a list, putting pen to paper. What are the areas in women's health that are, we call them opportunities because we didn't want to call them gaps. What are the areas where there is the most opportunity to advance women's health through R&D? And so in this almost year-long process, we had subcommittees, we broke people down into groups, we had a in-person convening on the NIH campus in Bethesda in July. We put people to work and we created this Women's Health Innovation Opportunity Map, which is shown on the screen right now. It is available on the NIH Office of Women's Health Research website, which I see is just coming up in the chat right now if anyone's interested, or if you scan the QR code on the left. And it shows, it's a summary. It's a great document. It's a great starting point for people who want to get involved, who want to learn more, people who are ready to take action. We've shared it with funders. We've shared it with advocates. We've shared it with our communication people. We want to share it broadly. It's a public good. We want to share it with everybody on this call and anybody in your network. It is meant to be a summary that was co-created by all of these experts and their opportunities for R&D to really move the needle forward. And it's really my hope that this document will be a sort of roadmap for people who are interested in women's health R&D. Like if they want to take action, but they don't know where to begin, they can pick up this document and use it as a reference or a resource. And then just to show that we are committed to this document and the opportunities represented therein, we're also releasing a funding opportunity. We put out an RFP, request for proposals, and that's the QR code on the right-hand side, where we will fund, I think, up to 3 grants in 8 out of the 10 opportunity areas for the next 2 years. If anyone is an innovator or has an idea for how to address one of these opportunities, as long as they roll up to the ones that are listed on the map, we will consider it for funding. So I'm super excited and energized about this, and it feels good to take action. So Dr. Eleanor, I think we've made a lot of progress, but we are not quite there yet. And I am excited to offer a way for people to move forward in a concrete way. Back to you.
Oh, thank you so much, Ru. Honestly, those statistics were so glaring regarding the fact that, what we learned in medical lectures being based, on a 70 kg white male. And at that time, we thought nothing of it. But, you have shown us with statistics and examples. The psoriasis one, it's really quite glaring. And yes, indeed, we need to take into consideration the unique needs of women and in the continuum and in the life course, through the life course. And no longer should women be, just looked at through the lens of their, reproductive system or organs. And it's great to see the level of commitment. So I invite those on the call to access the RFP around the innovation opportunities there and, share it with your constituencies. So exactly the same question to Dr. Metin Gulmezulu. Metin, for you, what does women-centered care and R&D look like? And what are your thoughts about where we are today?
Eleanor, and good afternoon, everybody. And thank you, Helena, for inviting me to this panel. Like Ru, I think I will focus on the R&D aspects, and I'm currently working at Concept Foundation, which is a small nonprofit NGO working in the space of improving access to quality assured sexual and reproductive health medicines in low and middle income countries. And in 2020, when we started looking at R&D, especially with regard to pregnancy complications, we found a paper in 2008 published, which looked at the maternal health drugs pipeline. This was a seminal paper by Rifat Atun and Nicholas Fisk at the time in 2008. And they had identified 17 medicines that are at current development at the time. And most of them were related to prevention of preterm birth and labor. So we started looking at, okay, what happened to these medicines? And can we pick up any of those to go to the next stage of R&D or implementation? And we started a project with support from Bill and Melinda Gates Foundation called Accelerating Innovation for Mothers in 2020, looking at this question. And what we found was quite depressing, actually. Not only those 17 drugs had simply disappeared from the R&D scene, either abandoned or research didn't show promising results. In some cases, research was deemed to be too difficult to conduct and stopped, even by large pharmaceutical companies. And we looked at the pipeline of maternal health medicines addressing different complications of pregnancy. And while there's a lot of medicines being researched and published in scientific papers, there's almost nothing that is actually developed purposefully for conditions that affect pregnant women. And then we started looking at the reasons for this. And we realized that in some cases, researchers could not conduct randomized trials because they could not secure insurance for clinical trials and liability. In some cases, there were not enough centers to conduct GCP-compliant, regulatory, good quality studies. So, and then we spoke to big pharmaceutical companies, innovator companies, and they actually showed quite what we could call risk averseness. And this goes back obviously historically to thalidomide and other tragic events, which were happening because those drugs in question were not properly researched and introduced into care without being researched and caused havoc. And that led to decades of scareness and abandonment of research from this field. So come to 2020, 2021, we had the COVID pandemic, and the first vaccine trials at the time when they were being conducted did not include any pregnant women, even though at the time it was known that pregnant women and babies and fetuses were vulnerable to COVID infection. And this brings a bigger problem where, you know, we often don't have good evidence, and I think the Conception Project is trying to address some of these questions, that we don't know what happens to drugs and how the pregnant woman's body reacts to these drugs and vaccines when they are administered. So what happens is, because we do not have the research evidence, we shift the responsibility to the care provider and the women. So in actual terms, what happens is the doctor or the midwife says, well, I don't know how safe this drug is, or I don't know the actual effects, but you probably should take it because in non-pregnant women or men, it has been shown to be effective. And that is simply not good enough. And that's why I'm referring to Ruth's important comment that this is a gender issue. This is an inequality issue. And that's why all these areas are underfunded, undervalued. And hopefully through the Innovation Equity Forum and these initiatives, we will develop more solutions and innovations in this space. Thank you, and I'll hand over back to you, Eleanor.
Oh, thank you so much, Metin, for giving us that historical perspective. And, just the thought that, pregnant women, it was being extrapolated and the burden being put on the caregivers who have to communicate this to pregnant women to literally, take things or do things by chance. Well, that's why we're having this conversation today. That's why we're having the conversation today. And that's why we've got our expert panelists with us. And the question now goes to Dr. Rishma Dilonpai. For you, Dr. Dilonpai, tell us, please, what does women-centered care and research and development look like to you? And, with your wealth of experience in the work that you're doing, covering, 3 key institutions in the field, where exactly are we today?
Thank you, Eleanor. Thank you, Helena, for giving me also a platform to share with all these amazing people who are working so much in women's health. I, of course, come from an area of clinical practice. I've been a practicing OBGYN since 30 years in a very densely populated country such as India, a very LMIC. We have scarcity of funds. We have difficulty in sometimes getting the resources that we need for medical care in many aspects of, in many parts of India. So I feel today, and everyone has emphasized that women really are the backbone of the family. So just looking after women's health almost ensures you better health of her husband, of her family, and for all the people dependent on her. However, still, unfortunately, women's health is an extremely underserved area for research, for funding, for innovation, particularly, and I underline more in LMICs, and we've seen it works across the world. Unfortunately, even in the well-developed nations, women-centric research is really much, much underserved. It has, women's health hasn't been a focus of research or funding for years. And if at all, there has been a little bit of focus, it has been on the reproductive age group. The other extremes of a woman's lifespan, the adolescent phase, the perimenopausal, the menopausal phase, it is completely neglected. Considering women spend 1/3 of their life in menopause, that area is completely underserved. In fact, we've been given some wonderful statistics by the previous speakers. In 2020, there was a research by McKinsey, which said that outside of cancer, the amount of funding which goes into women's health research is only 1%. So out of the $198 billion being spent, 1% was on women's health. And in the cancer segment, it was only 4%. So this is recent. This is only 2020. And this is the situation the world is in. So it's obvious that, when NIH and Bill Gates Foundation approached me for coming for this Innovation Equity Forum, I really jumped at the opportunity, because working for 30 years in OBGYN, knowing the problems that we have, the minimal research that is going on, the large gaps that are there, the opportunities that are there, which are unfortunately being underutilized. I really wanted to work with all the amazing people over there, 250 of them from different fields, innovators, researchers, NGOs, government people, clinicians, femtech entrepreneurs. So it was such an amazing opportunity to get together and to try to bring together the most important aspects of opportunities in women's health and how we can actually find solutions in that area. And so, we realize that we have so many unmet needs. The most difficult part in that Innovation Equity Forum was to narrow down the choices. We had literally tens of hundreds of opportunities that we wanted, and everybody was so strong about, their, sort of presentations or the problems that they were facing. And eventually narrowing down to, say, 10 opportunities was really the most difficult aspect over there. So there are so many, areas, and I chaired the segment on female-specific health conditions. And, and as said earlier, there are so many conditions which affect women disproportionately or differently, and which are, really understudied. So we really need innovations that address the reproductive, maternal, gynecological, and life stage conditions. So we kind of narrowed down on a few important opportunities, and I'll just discuss some of them with you, or just in fact enumerate them in fact for you. So some of the important opportunities were developing tools and therapies for prevention, diagnosis, and treatment for conditions such as PCOS, endometriosis, fibroids. They affect 20% of women are affected by endometriosis and fibroids. 35% of women in some parts of the world experience PCOS. And these have impact on the quality of life, on their day-to-day, work conditions, absence from work, ability to, function as healthy women and contribute to the world. So all of these conditions, we yet know so little about them. To study the vaginal microbiome and interventions to address the vaginal dysbiosis. Every day, millions of women suffer from recurrent vaginal infections. We treat them, they come back again in a short period of time. Increase the research on prenatal, intranatal, and postpartum conditions. Even today, every day, 800 women are dying during pregnancy or childbirth. Every day, we're losing millions of lives to postpartum hemorrhage, preterm labor. We really know so little about how to diagnose, how to prevent preterm birth. Imagine a baby who's born really early at 25 weeks, 26 weeks of pregnancy. It's a lifelong support that we have to give that child. Look at the financial implications. Look at the effect on the entire family. It will destroy a family if they have one preterm birth in their family sometimes. So we need massive research in these areas. Pregnancy-induced hypertension. It's been a killer since years. We don't even know why it happens. We have no new drugs for it. We are using normal blood pressure drugs, which we use for men. We are converting them for using in pregnancy-induced hypertension, though the disease, the pathology is completely different from normal hypertension or high blood pressure in men. We need to understand one of the aspects we focused on, the role of micronutrients, iron, folic acid, how to give the best combinations to women. We need to create biobanks and milk and blood samples for research, because the moment it comes to pregnancy, you read a drug label, not tested in women, not safe in lactation, or we have no information. So many times we need to go on the internet and research it. We find no information on certain drugs for pregnancy and lactation. Definitely, contraception is an area which is completely under-researched. Even today, we have no, forget perfect, far from perfect contraception, completely lacking. We need to support all the policies that impact women's health. What about fertility? Today, WHO came out very recently saying that 17% of couples experience infertility, the disease of infertility. What is the work we are doing on that? Women are showing, early ovarian aging. How do we affect that? Men's health, men's fertility, which is impacting, women. Women are blamed for infertility all the time, but very often the couple actually has a problem. So we need to work on that area. new biomaterials. Mesh was used for prolapse in women, and then they found that it had so many problems. After a few years of research and usage, and millions of women had mesh put into them, it was found that it was not safe. It was causing a lot of problems. It was removed from the market. So this is not going to work. Millions of women are going to suffer because they had mesh put inside, which later on was recalled. So we need good biomaterials, stem cell research, all of this. And lastly, one of the areas we focused on was on the diagnostic and treatments, basically, for menopause symptoms. Even today, we have no good drugs for hot flashes, for, genitourinary syndrome of menopause, recurrent urine infections, stress incontinence, osteoporosis. So I can go on and on as a clinician on the large number of gaps there are. But I can just in 2 minutes with where we are today. So let me be a little more positive. Let me not focus on the gaps. Let me say that the positive aspect is that we are talking about it today. The Innovation Equity Forum, for example, brought together so many stakeholders. It's out there, the opportunities, the gaps, the way we can, fill in, plug in for those gaps. So that has made a huge difference. We have celebration of Safe Motherhood Week going on right now. All of us are focusing on it. This is a good beginning point, right? There's so many women now in positions of, where they have a voice, where they can represent women. So femtech, femtech has become a big buzzword. There are conferences, meetings, entrepreneurs, and all of them are working towards improvements in this area. So let us hope by platforms such as these, we will bring about a lot of improvement in R&D. Thank you. Thank you so much.
Oh, thank you, Rishma, with such great passion. You're so correct. I remember being there at, the Innovation Equity Forum, and having to take that difficult decision of, what are we going to prioritize? And, I was saying, look, we can't even, go the hierarchical route. But, here we are having the conversation, which is a brilliant start. And what a beautiful space for us to really, talk about how we can make a difference. And we are here because we can make that difference. Marilyn, we would like to hear from you. What women-centered care R&D looks like. You're raring to go, so please take off.
Thank you, Eleanor. Thank you, Elena, for inviting me to the forum. And I must say, it's not the easiest place to be the last in the row, I must admit, because a lot of what has been said is just, I'm fully agreeing to that, and I couldn't word it better than the previous speakers did. So I think I have a little bit of a different angle that I come from. I work for Novartis, which is of course known as one of the big pharma companies, but as part of my role, I'm also involved as a project lead for IMI Conception, which is a huge public-private partnership where academia, public partners like teratology information centers, and also pharma companies work together to address really the big questions around medicine safety in pregnancy and also in breastfeeding. So for me, women-centered care is really based on my belief that a woman has the right to use safe and effective medication that is based on scientific evidence, that we have data to support. And, very honestly, because she's not only taking a decision for herself, for her own health and her own treatment, but it is also having a major implication for her unborn or maybe newborn baby. So, and that comes back really to very simple questions. So how do you know that the medicine is prescribed to you when you're pregnant is indeed safe? And can you continue to breastfeed your baby when you're taking that drug? And actually, when I was preparing it, and I started thinking about it, said, well, it's almost 2024, and we still need to ask those questions. Well, you would have hoped that the world has changed in the meantime. So there's clearly a gap that we need to fill. And especially, and I don't want to throw a lot of numbers in addition to what the previous speaker said, but we did a little investigation on the information that is available in patient information leaflets in the EU, for example. And we found that there was like 70% of the labels did not have any information on the use of that medicine in women. And there were like 80% of the drugs that there was no information available on the potential effects during lactation. So based on these numbers, I think it's really clear that we need to make sure that this type of research is being done, that data are generated, and as important, that also that the information becomes available to patients and their healthcare professionals in a comprehensive and understandable way. Because we cannot expect from a healthcare professional or a patient that he or she starts searching scientific literature to find the right information for specific women, and to make and a very different point, and it was something that I just came to my mind, is I checked the Dutch press. I'm from the Netherlands, so that's my easiest read. And in the last few months, I already noticed there were two major headlines on women in healthcare. And the first one was about 2 months ago about the reimbursement of reconstructive surgery after cancer, where the analysis of the investigators showed that all reconstructive surgeries in the Netherlands are reimbursed without any questioning, except for female breast reconstructions, where insurance in the Netherlands ask for photos or reject applications on the basis of just a paper dossier. I found it quite shocking. And the other example was just a week ago. There was presenting a study which showed that for certain types of cancers, male patients were more often offered a curative treatment, while women get more often supportive care. And of course, we don't know much about the reasons behind that because that was not investigated there, that was not able to extract. But just the fact that there are differences is already, I think, striking to me, and shows that the gap is not only on the information and the data that we have available, but it's on all different levels. It's the research that is being done. It's the treatment that patients or women get, and I think to make steps there. A forum like this for me is just a unique opportunity to start flagging it, to start being loud about it and vocal about it, because although it's almost 2024, I think we still need to do a lot of work to, not only to get better, but to get the best and just do good. Thank you.
Oh, Marilyn, indeed. It's not just for us to get better, but for us to get the best. Truly shocking, just these two press examples that you have given. And the gaps do exist, as you said, at all levels. For us, as the Medical Women's International Association, we have something called the Worthy Campaign. And Worthy is spelled WORTHI, and it stands for Women's Rights to Health Information, where we're making it and saying it's a human rights issue, and they have the right to have access to that information. Like Ruth said, they're the chief medical directors in their homes. So if the chief medical director doesn't have the correct information for herself, let alone her family, let alone her unborn child. So that's what we're hearing. So I know that there are burning questions, but before moving on, we're going to please turn our focus to patients in the audience. We want to hear from them. And today, with us on the call from Make Mothers Matter, we have Johanna Shima. Johanna, we would like to hear from you. Please.
Thank you, Eleanor. Thank you for the invitation, and just a few words, and you have more information on the chat about us. We are an international NGO established since 1947, working for representing, defending, and supporting mothers as agents of change. And we are active in front of the UN, the EU, and the UNESCO. I'm sorry, Eleanor, but I'm going to bring more issues to this table because there are still some hot points that are not being yet so much discussed. But I'm also going to provide, hopefully, with some recommendations. Some are more difficult to tackle, some are easy for everybody to do. And this topic that I would like to bring today is the mental health of mothers. First, I would like to bring the facts. Fact number 1, motherhood represents a period of enormous change in women's life, both physiologically and also psychosocially. And nearly 1 in 5 women worldwide will develop mental health problems during pregnancy or within the first year postpartum. Depression is the most common major complication of maternity, even compared with the other complications that we have heard today: hypertension, preterm diabetes, preeclampsia, etc. And in many places of the world, I work at the EU, so including the EU, is a leading cause of maternal death. Second, mental health of the mental health of the mother during the peripartum period is as important as her physical health. Third, the first 1,000 days of the life of the child are a critical time for the development of the child, as it provides the foundations and determines the child's development and lifelong health, both physical and mental. So this begins with the fetal development and depends in large part on the health of both physical and mental of the mother. The well-being of mothers throughout their pregnancy is therefore paramount to both fetal well-being as well as early childhood development. Fourth fact, living maternal health problems untreated has long-lasting consequences and detrimental effects on the mother, like the increased risk of further clinical episodes, on the mother-child relationship, like the bonding, and on the child, like social-emotional and cognitive development. Fifth, trauma and adversity during pregnancy at the first years of life have been shown to be a predictor of poor mental and physical health, even across generations. This means that the damaging effects are not only experienced by the individual mothers themselves, but by their family and their offsprings and the offsprings of the offsprings. 6, for children living in poverty, it is not only the poor conditions themselves that have the greatest impacts and negative impacts on them, but it is the mother's emotions and internalization of poverty that gets passed on them, whether they can be as early as in the womb or as the child develops. 7, poor maternal health is strongly influenced by various social determinants, such as gender discrimination, violence, lack of social support, socioeconomic status or poverty, substance abuse, natural disasters, among others. And 8, in a study done in 2014 by the London School of Economics on the specific cause of maternal mental illness, demonstrated that for each 1-year cohort of co-births, the estimated cost was up to £8.1 billion. 2/3 of this comes specifically from the long-term impact on how a mother's mental health can affect that of her children or child. So what can be done with these striking facts? Considering that also, this is a very important point, and it's a fact, that the peripartum period is the most efficient time for detecting depression in women and other mental conditions, since it's the time when most women come in contact with the health system, regardless of the economic or social background. Therefore, this is a great window of opportunity to intervene, both in the physical, but also in the mental health. So what are the recommendations that we at Make Mother Matter bring to the table? One, to integrate quality and accessible mental health services and resources for mothers, ensuring that the support extends beyond medical settings, to provide with basic training of maternal health providers in mental health promotion, screening, and early detection. to provide also access and availability of psychotherapeutic treatments and other non-pharmacological and non-invasive interventions, including support research in this area. Also to develop universal screening tools and clinical guidelines. One example of this is something where we were involved as an organization with the EU research project, Rise Up PPD, where we just published, together with the researchers, EU clinical guidelines on screening for and treating peripartum depression. Another recommendation is to formally recognize pregnant women and new mothers as a vulnerable group in a society, in order to provide them with more protection within our health, social, and legal systems. Also to develop decentralized and community-based mental health services, both during pregnancy, but most importantly, to follow throughout the first 1,000 days of the life of the child. To set maternal mental health at the forefront of the public agenda, to break the cycle of intergenerational transmission of trauma and adversity, thereby reducing the immense financial cost of perinatal mental health of mothers. Also to acknowledge and raise awareness that caring for mothers is a positive intervention for long-term social development, and that it calls for allocating the appropriate funding, since the earlier the investment, the greater the return. One important point is also to address the stigma, to create an environment where mothers and their family can discuss and be comfortable seeking help around mental health. To improve maternal mental health literacy, to learn, for example, which are the warning signs to look for by the mothers themselves or by the others. And finally, to know that prevention is not only the job of clinical practitioners, but a collective responsibility. So I would like, Eleanor, and to all the audience, to finish by saying that we all can help the mothers around us, the so-called village. We can all be their village that supports them during this period, because not only this is only by nurturing our nurturers that we can bring about the meaningful changes that we all want to do and improve the well-being of our society. And therefore, I invite you to join us, to join MMM in bringing bringing this issue of maternal mental health by breaking the silence on this important topic. So many thanks, and yeah, happy to be sharing with you this today.
Oh, Johanna, you know, the way you emphasize the economic cost to not addressing mental health. And thank you for taking us from that onto the enormous opportunities. The fact that, you know, you've come up with guidelines, MMM has done that. We must break the silence. And coming from Nigeria, where sadly mental health is so stigmatized, it's how we can, you know, make a conscious effort of, you know, making sure that survivors are not stigmatized. Again, the role of the mother in the home, in the community, and the whole society. Thank you so much for that. I know that there are burning questions, but I'll crave your indulgence. We have just one more speaker, and I'll ask you very kindly to keep it short and succinct. Candice King from Genomics, can we kindly hear from you? After which we're going to open up, you'll be able to unmute microphones and ask questions by raising your hand. But first, please, let's hear from Candice.
Thank you so much, Dr. Eleanor. Unfortunately, my camera seems to not want to work. I think my connection isn't the best, so you'll have to just make do with my voice. I hope that's okay. But yeah, my name is...
Absolutely fine.
Perfect. My name is Candice King, and I work at Genomics England in the Diverse Data Initiative. I'm the Patient and Public Engagement Manager, and the Diverse Data Initiative aims to reduce health inequalities and improve patient outcomes in genomic medicine for minoritized communities. And we have a major program looking and focusing on maternal health, and aiming to do some research in the areas of genetics, genomics, and maternal health. And I just really wanted to share some of our early engagement workshop findings. We commissioned a number of community groups to do some engagement and involvement of women and birthing people from minority communities, looking around barriers to research and cultural beliefs around research. And we found that this advocacy for culturally sensitive research practices is really important. We found that ensuring studies include diverse participants in the design phase of research, respecting and embracing those cultural differences, and providing safe and culturally relevant spaces to listen and to hear about unique challenges and barriers to being involved and participating in research is crucial for more effective and inclusive outcomes. And I thought I would just share some of the points that were raised in this work, and it was around committing to transparency about the research process and how we do things the way we do, and also thinking about privacy measures in all materials, and especially around long-term use of data and consent procedures that kind of make sense and involve people in the design, as opposed to just presenting people with something that's already been done. We also heard about the importance of employing community members to disseminate research findings and engaging mothers or birthing people who would be designing research with us as equal partners and not just subjects, and providing those regular progress updates and maintaining a relationship other than just one and done type of engagement. We also heard that whilst we'll be investigating genetic factors, it's really important to recognise how structural inequalities and inequities profoundly shape maternal health outcomes in underserved groups. And again, not shying away from conversations that need to be addressed and historical abuses of trust and mistrust in order to talk about what it is that we would like to be talking about. So that's very brief, just a top line overview, but thank you for giving me the opportunity to share, and I will post links to my LinkedIn in the chat if anyone wants to have a further conversation in future.
Thank you, Candice. We heard you loud and clear, about, working around culturally relevant spaces. Indeed, it's not one size fits all. We are not homogeneous. We are one humanity, but we are not a homogeneous group. And hugely important, as you said, for mothers and birthing people to have that respect as equal partners, right? And not as subjects. Thank you so very much, Candice. Now's the time. I'm going to see if I can, yes, I'm not seeing hands yet, but do raise your electronic hand, or if your camera is on and you wish to speak to what has been already said, if you have a burning question, if you have an experience to share, we would love to hear from you. There we go. Wajiha. And when you do speak, kindly let us know. We see your name, but let us know what part of the globe you're speaking from, and possibly the area in which you work. So Wajiha is one. Go ahead, please.
Thank you, Dr. Eleanor. I'm Dr. Wajiha Rizwan from Pakistan, and I represent MWI as I am president of Medical Women Association of Pakistan. I'm a pediatrician, a child specialist, and working in the University of Child Health Sciences, Lahore, which is the only university of child health in the world. I just wanted to add that as a pediatrician, I noticed that many times mothers, when we talk about mothers, many times they visit hospital only when the child is sick. Many times I have encountered such women who have delivered babies at home, and then they come with their child when the child is sick. And I have noticed that the child health is directly related to the mother's health. If the baby is anemic, I always check mother. She's also having anemia. Then I also prescribe supplements such as vitamin D or iron supplements to the mother. I just wanted to highlight and ask whether we are considering this gap while talking about mother health, that we are taking pediatricians on the board. I was, as a pediatrician, I haven't been taught about dealing mother depression or anxiety. That is one of the major reason when the child is sick, and many times it is related to the mother depression. She is not taking proper care of the child, and vice versa. When the child is sick, the mother goes through a lot of mental trauma. And many times I also think that in the pediatric or child clinics or pediatric health facilities, if the TV we have on the in the waiting areas, if we also display information about women health, such as breast cancer screening or regarding her nutrition, it could be of great help.
Thank you so much, Dr. Rizwan. Were you directing your question to any panelist in particular, or?
Eleanor, can I say something?
Oh, by all means.
Yeah. So
okay, all right. Well, just a second, Mandakini. Do you mind, Dr. Mandakini, if we can
go ahead.
Possibly have Dr. Rizwan's question answered, or did you want to speak to that question?
I just wanted to add that they said that they have created a map regarding women health. Have they in that map identified that gap area that the pediatricians can be taken on board while improving the mother health?
Thank you. So that's the opportunity map. It sounds like it's your question, Rue.
Yeah, no, thank you for that question. I mean, I think that's a great opportunity that you're pointing out. And I know in the US, which is where I'm based, pediatricians do some mental health screening of moms when the babies come for their, those early newborn visits. Whether or not it's called out specifically in the map, it's, I think it could roll up under one of the areas of the map. And I don't know off the top of my head if it specifically is called out in that way, but 100% agree that opportunities exist where care intersections with the care system when they take place should be maximalized and optimized to provide support for the child, the mother, whoever shows up to the care setting. So fully support that.
Thank you so much, Rue. Indeed, women inextricably linked with their children. Dr. Mandakini, were you trying to speak to the same issue, or did you have a different question?
No, I'm just trying to make a remark, especially very, positive remarks from the Southeast Asia region, and that too from India. Let me introduce myself. I am president of All India Association Medical Women of India and was vice president with the Central Asia region. And I had the privilege of working with Dr. Eleanor for last 3 years and extensively happy to work with. Eleanor, thank you very much for this webinar. Now, I just want to share that in India specifically, we could achieve the SDG goals which were in 2030, we have already achieved. Like our maternal mortality has come down in 2 states, that is Kerala and Maharashtra, which is on par with the already achieved the SDG goal, that is 30 per 1 lakh. So here I will like to just share my experience that in India, our maternal health, that is safe motherhood, is being taken very, very seriously at the government level, because we have a lot of infrastructure, training, and also the referral is very strong. Because about 80% of the people are in the rural area, there was a lot of transportation. As I could hear so many issues of policies and supply. But here we have consistently improved in the referral training of the doctors. Even the MBBS doctors get taught to do the cesarean section. Pediatrician is there. We had the local MBBS doing the pediatrics also. So all this has led to a very positive impact on the safe motherhood, and also the government herself is doing a lot of schemes like Rishma knows about it, Prime Minister's, safe motherhood, high risk pregnancy, Janani Suraksha, where actually government is giving the grant for the women to deliver in the hospital. And now we are almost 99% hospital deliveries. So all this has led to a very positive impact on the mother's health. And this I want to share with all the nations, because so all the experts are here, that few policy which can make a change will always be your expertise to the government and to the policymakers will be a great thing, which I really want to share, Helena. And Reshma was one of the person when she was FOXI president. She has done great work as the Prime Minister's, Reshma. And we all are doing as a women FOXI presidents and FOXI ICOG chairperson in India. So great to work with you, Elena, and everyone here for this opportunity. Thank you very much.
Thank you so very much. Lovely to hear about the Prime Minister's incentive to get women to deliver in hospital. Dear friends, you've heard from members of my constituency. That means that I won't be deposed as president. Now, on to Andy. Andy, Andy, your hand was up. Let's hear from you. Just unmute yourself.
Good afternoon. Nice to meet you all, and thank you very much for some very interesting presentations and insights into challenges around women's health. And indeed, I placed a comment in the chat highlighting some of the challenges that we've seen personally, including significant lack of investment, some of the lowest patent submission and growth, R&D investment, and only 4 FDA breakthrough device designation submissions in the last 8 to 10 years associated with women's health. So all the points here resonate, and I think, Rue, your comments as well about the lack of investment. I want to share some of my own experience, having worked in medical devices and development at an exec level for the last 30 years, working across orthopedics, infection prevention, implants, and now the last few years within women's health. And I represent a company that's invested millions significantly into a specific development to deal with some of the challenges for postpartum hemorrhage. We know that a woman dies every 4 to 5 minutes around the world from postpartum hemorrhage. And one of the leading causes, not the leading cause in many countries, LMIC regions, of maternal mortality worldwide. And indeed, when women don't die from PPH, they're left with significant disability, surgical interventions, and significant blood transfusions, which, having recently engaged with the likes of COBA, I see what a challenge that is in Africa, where 55% of all the blood stocks are not available to deal with oncology patients, road traffic accidents, etc. So we've invested very significantly. We have a device called Celox PPH. Some of you on the call may be aware of the device, and we've been certainly around the world investing in growing our sales channel, making submissions for CE marking. In fact, we got the CE marking for this product late last year through the medical device regulation. And again, those of you familiar with the medical device regulations, as it changed from the MDD, will know how notoriously hard it is to invest and put the work in to get the clinical data to support a submission to get approval for said device. And indeed, we got that last September with some very, very impressive clinical data from Charité University Hospital in Berlin, amongst other centers, publications going back over 12 years, showing 100% success with the device in level 1 and 2 bleeds, and a 95.6% overall success in level 1 to 3 bleeds. And indeed, I think the way that the product works is independent of the blood clotting cascade, so offers a unique opportunity with a very unique mode of action to really address some of these huge mortality rates we're seeing in Nigeria, well over 900 per 100,000 live births. Massive challenges. They shouldn't be above single digits, if not 20 or 30 maximum per 100,000 live births, with access to the technology. So then I guess it comes on to the crux. So we've worked very heavily with these organizations around the world, the Bill and Melinda Gates Foundation, UNFPA, aid organizations, Concept. We've had pretty much calls with everyone. But I guess my experience, and this resonates from some of the comments Metin made about the 17, I guess, innovations that you saw in the early days, and then later on when they reviewed them, many of those had disappeared. And I just want to resonate how hard it is as a commercial organization to not only establish a sales channel and get authorized reps in country and apply for what can be 6 or 8 months to get approval within each of the country, but sometimes our biggest barrier is kind of the organizations themselves and the guidelines that are in place. And where we've reached some resistance in some countries, mostly down to the fact that some guidelines that haven't changed for many years or don't reflect or embrace innovation. And whilst we're not saying necessarily that they should be universally embracing them as an approved technology, there is no route or pathway or recognition or I would say embrace from these organizations to say we want to invest behind and support industry to develop innovation, even if that's in a meaningful format through well-controlled evaluation programs in 1 or 2 countries to prove out technologies, particularly for a device like ours that's got 12 years of clinical data and has CE mark approval with the medical device regulations. It almost goes against the MDR in the first place to suggest that the MDR would approve a product that would not provide benefits to patients or outcomes for patients, when we know that the MDR is one of the most rigorous organizations to actually get a device through. So I guess it's more of a comment, and I think it was just picking up some of the points that Metin raised earlier on, and Rue as well, being Bill and Melinda Gates Foundation. We are open arms to anybody out there that wants to work with us to collaborate, and we've already had meetings in many areas to suggest that we would be very happy and prepared to invest behind that. But we're open arms to anybody that wants to come to us and say, yeah, we'd like to approve or we'd like to review the technology. But I think it's got to be a two-way thing, because I think in many ways we feel like there's a big push from a commercial perspective, but sometimes our biggest blockage is coming from the clinicians, from the clinician groups, the organizations that set very rigorous guidelines that clinicians will adhere to. So I really just want to throw that out as an invitation, if you like, but also just something that I believe significantly could change the face in the way that innovation is adopted and scaled up. Thank you very much.
Oh, Andy, we hear you. Oops. Yeah, we hear you loud and clear about needing that pinnacle of commitment, needing us all to be, part of ensuring that these, that there aren't those bureaucratic bottlenecks, and, to think of, the amount of data-driven work that you have, and then to meet some of these blockages. So we have to commit to being that voice of advocacy to drive this forward. Thank you for sharing that. Banjia?
Bahija.
Sorry, Bahija.
Hello, everyone. Thank you for this great and nice presentation. And thank you to all panelists for this webinar. Thank you, Helena, for the invitation. My name is Bahija from Bahija Guimi. I'm running an organization called Amal based in Marrakesh, Morocco. And I am myself a patient living with leukemia, CML, since 2002. Now, my comment is not a question, just we have, I think we can improve women's health. We can't do it without a holistic approach. We have to improve education and economic issue, and also raise media and public awareness about women's needs. We can improve that, and we can go for innovation. Now we are talking about, innovative solutions and artificial intelligence. Without diversity, we have to include women. And also, as I mentioned before in my chat box, that's one comment, that we need to encourage women to be involved in research, because we have less than 30% of world researchers are women, and we need women because women can defend women's rights and also speak about other women and defend them. I think also we have to train women, new leaders, because in low and middle income countries, women are less self-confident. We have to encourage them to lead in private or public or academic sector. We have to put some women because they know very well what women are struggling with. Thank you very much.
Bahija, thank you so much for, sharing with us. And, absolutely agree with you. It has to be holistic. We need to co-create. At this point, I don't see any other hands, and I think it's a good time to hand over to Helena. And you've got a surprise for us, haven't you?
Thanks, Eleanor. So it's been lovely to hear from some of you already, but we'd actually like to hear from all of you in the audience. And so we have prepared another poll, which is the following. So what we would like to ask you to do is actually rank some dimensions that were identified in the Women's Health Innovation Opportunity Map that you have been hearing about throughout this panel discussion. In the next slide, you will see a Slido opening up, and if you still have it open on your phone or the computer, it should be the same link. And you will be able to scroll down. So there are more than 3 options, and what you can do is just select, I think, up to 3 of the opportunities that you believe are the most important to focus on. So important in the sense that it has the most potential for impact on patient outcomes in the next 12 to 18 months. So we kindly ask you to have a look there and share us what you think. And I think this would be quite an interesting outcome for us all to reflect on as we close up this panel discussion. And then after we do this, perhaps we can invite the panelists to share their reactions and potentially their concluding remarks to wrap up the session. So we'll all give you a minute or 2 to do this. It's great to see the answers coming in. And as you do this, I will mention that there were about 50 opportunities in total, which is why we didn't include all of them here. We just selected one from each main category of focus. But at the end, what we'll do is we'll share the link again to the opportunity map, and then you can have a look and share your feedback on all 50 dimensions as well. So the way that it will work as you respond, the ones that you see on the screen will be the ones that are the most that are ranked the most high. So you see we're tied number 1 right now. And again, we'll give you another moment to answer because we know that there are quite a few options to read through. It looks like advancing sex and gender intentional research design and analysis is number 1 so far. Increasing representation of women. Oh, no, that one is dropped. Creating a partnership is one that seems to be interesting for people. And then the representation one is number 3. We'll give a minute just for that last person to finish ranking. And then potentially we can move over to the closing remarks. Okay, back over to you, Eleanor.
Now, that was so interesting. Thank you so much, Helena. Okay, so in reverse order this time, I would like to go back to our panelists and ask you to leave us with your words of wisdom. We have spoken a lot about the gaps and the opportunities. What is the word of wisdom that you're going to leave with us to send us out as ambassadors for women's health R&D? We are ready. Send us out. Marilyn, we'll start with you.
Cool, thank you. To be the first one this time. No, I think for me it's really easy. It's collaboration, collaboration, collaboration. We need to come out of our silos. If we are in a pharma company, we need to start talking to patients. We need to, if you are a patient, you need to start talking to your doctor. If you are a doctor, you need to start talking to pharma. And it all comes together in bringing all our qualities and expertise and experience together, because I think that is the essential part that we will need, and that will help us. And that's also what we try to do in IMI Conception, is bring all the different parties together, because we all need the different angles, the different qualities of each other to address the questions that are still out there and that needs to be addressed urgently. So and especially for conception, then it's of course focused on medicine safety in pregnancy, medicine safety in breastfeeding, and how to reach and bring the knowledge and the data that we generate back to the patients that are in need of the information. So I think collaboration for me is really the buzzword, and it's the thing that we need to put all our efforts into.
That was so loud. It was so clear that the first three things we need are: 1, collaboration; 2, collaboration; and 3, collaboration. Over to you, Rishma.
Thank you. I feel collaboration, of course, extremely important, but also raising awareness. So awareness is important. We've all realized today how minimal the focus worldwide is on women's health, research, innovations. And if we create awareness on all aspects of women's health and just bring out the fact that sex and gender differences can have a significant impact on how medical conditions affect a person, how drugs affect, gender differently. So awareness is very, very important. Collaborative, multidisciplinary approach, co-creation. So all of these are extremely impactful. And I think we've made a wonderful beginning here. It's just forward and onward from here. Thank you.
Thank you, Rishma. It's lovely to see the building blocks of collaboration and then raising the awareness. Metin, you're next.
Thank you, Eleanor. As Marjolaine was saying, if you are close to being last, it becomes more difficult to find new things to say. But I think the power of advocacy should not be underestimated. And in saying so, specifically patient groups, civil society organizations, and grassroots organizations have a huge role to play, particularly for promoting R&D, because I think if we just say promoting women's health, promoting maternal health, it gets diluted, the message gets lost. But what is needed is R&D, innovations for this space. And I think we need to advocate for that. And if we can do 1/3 or 1/4 of what the HIV/AIDS community did, I think we would go a long way in achieving our objectives. And lastly, I think we need to get out of the high-income country, low and middle-income country divide in this, because the problems that affect women and pregnant women and non-reproductive age women are common to all women, both in lower income and higher income countries. Thank you.
Whoa. Metin, Indeed, the power of advocacy. And I like, how you referred to the importance of the messaging that, just has to be consistent. And that example around HIV and AIDS, I recall working in that era and the huge stigma. In fact, I started out in development, leaving clinical work when widows were being labeled as carriers. So, the man died because the woman infected him, and harmful cultural practices were brought to bear on, widows of men who died of AIDS. So we have so much to learn from, as you say, the HIV and AIDS example, and there shouldn't be any geographical divide. Let's make sure that women of whatever geography, whatever phase they are, from the womb to the tomb, have access, and it should be affordable. Last, certainly not the least, we would like to hear your words of wisdom to us, Rue, please.
Well, I have to say, being the very last person to speak, it is hard to come up with something that hasn't already been said. But I will say from this panel, what we've heard, and from the patients and everybody who's participated, there are so many areas where there's opportunities to move the needle for women's health R&D and for patient-centered care. Coming from the Bill and Melinda Gates Foundation, the second largest funder of women's health R&D globally, I will say we cannot do it alone. We need to all come together. We need to break down the silos. We need to harness the energy of this community and use it to ignite action. We need to take a step forward. So everything that was stated around collaboration, raising awareness, advocacy, fully agree that the challenges faced in high-income countries are not different from the challenges faced in low and middle income countries. And so we are part of the same global humanity. So I think my parting thought would be around investment in women's health R&D. I think there is a true business case here. There is a high return on investment. That's actually what we say in the opportunity map, that these are 50 high return opportunities to advance global women's health R&D. So women's health R&D is a strong business investment. You will get your return on the investment, and it's a smart business decision. And we have to do it together. We cannot do it alone.
What a beautiful way to sum it all up. It's a smart thing to do. We will get the return on investment. And as one humanity, doing it together. One of the things I say is we do it elbows locked. I lock my elbow with yours, you lock yours with mine. And like the African proverb says, if you want to move fast, you move alone. If you want to go far, we move together. We want to thank our organizers. Thank you, Helena and team, for making this panel possible. Thank you to the panelists from the different time zones. Thank you for the responders from the audience, to our patients and survivors who shared a bit of their personal stories. Shall we give an electronic clap to the organizers as I hand over to Helena to please conclude? Either electronic or physical. A round of applause.
Thank you, Eleanor. And I should say, I was going to say, please give a round of applause to Eleanor, because I think we have been so impressed by your moderation, the lively, elegant style that you always bring to these kinds of discussions. So it's really been an honor to spend time with you and with the other panelists. So thank you so much. Really, really appreciate it. It's been a fabulous discussion, and I'm just so excited by all the ideas that have come from this. I wanted to mention just a few last words. So as I mentioned already, it's Safe Motherhood Week. And so we actually have a campaign page that we will be sharing shortly in the chat. And if you visit this campaign page, you can learn more about how to get involved. You can also discover the opportunity map that we have been talking about in this panel through the campaign page. And you can learn more about all the different 50 opportunities that are identified. And in fact, there is like a long form report that is almost, I think, 200 pages long. So there's plenty of great material in there that you can browse through, or if you prefer a short executive summary version. We have also linked to a public consultation that we have put together with the other collaborators with the Innovation Equity Forum. So you also have the opportunity to share some feedback. So that would just be great to hear from you. And please forward these materials for the campaign to your network and reach out to us if you would be interested in participating in incubating a collaborative partnership to address these issues. I just wanted to restate what Rue had mentioned at the very beginning of this discussion about the opportunity to apply for funding from the Gates Foundation. So please have a look there. And we will be sharing a feedback survey for the PEOF session. So please respond to the feedback survey. We want to hear from you and potentially ideas for what we can do in the future. And then finally, Daniela, if you could just share the last slide, I wanted to mention the next sessions that are coming up. So in December 13th and December 15th, respectively, we will have one session on patient engagement and patient experience data, and another one on leveraging technology to drive matchmaking and community building. So look ahead, tune in. But thank you again for joining us. Thank you again to Eleanor and the panelists, and I hope you all have a wonderful rest of the day.
Thank you.
Thank you so much.
Bye-bye.
Bye, everyone.
Thank you. Bye-bye.
Thank you.